Good morning, one and all. At the outset, I would like to thank RIC for this opportunity. So, I would be discussing about the relevance of foveal double layer sign in geographic atrophy. So, in healthy eyes, RP and Bruch's membrane cannot be differentiated, and we use the term RP-Bruch membrane complex. It's a single layer. In some situations, there is a shallow separation between the RP and Bruch's membrane, which is termed double layer sign. It can have homogeneous hyporeflectivity or it can be heterogeneous. A heterogeneous double layer sign is important as it can be a sign of presence of a macular neovascularization, as we can see on OCTA. So, it is a surrogate marker of macular neovascularization with a good sensitivity and fairly good specificity. So, this is a case in which we can see coexistence of both macular neovascularization and geographic atrophy. The projection image shows the temporal geographic atrophy with presence of quiescent macular neovascularization at fovea. A retrospective study identified that presence of a foveal double layer sign is protective against progression of geographic atrophy. So, this is an example from that article. So, we can see that there is no DLS. Here we can see that there is a very fast progression of geographic atrophy towards the fovea, whereas here in a patient with presence of DLS, the rate of progression is slower. We can see that the fovea is still preserved. Similar observations have been noted in other case series in which they noted that the presence of macular neovascularization is protective against geographic atrophy. Let's try to understand this. So, a possible mechanism would be that like the OCTA studies have shown that eyes with a few areas of choriocapillary loss at baseline tend to have a slow progression of geographic atrophy, and eyes with more areas of choriocapillary loss show a rapid progression of geographic atrophy. So, it may imply that a low choriocapillary density means that there is lack of nutrition to the overlying RP and outer retina, and this is a faster GA progression. And we also understand that the choriocapillary loss precedes the development of geographic atrophy. So, in an eye with coexistent geographic atrophy and MNV, the capillaries within the MNV would provide nutrition to the overlying RP and outer retina so that it can protect that area from progressing into geographic atrophy. So, let's look at example. So, it's a 72-year-old lady with foveal sparing geographic atrophy at presentation. There is possibly a thin DLS, which is mainly due to the accumulation of basal laminar deposits. And on OCTA, we can see that there is no evidence of flow signal. So, this is not a quiescent MNV. This is a thin DLS, which is mainly an accumulation of basal laminar deposit. In this case, over a period of 18 months, we could see that like she showed a very rapid enlargement of GA and even towards the fovea, as we can see that there is almost a complete retinal and outer retinal atrophy at fovea with drop in vision. So, it is only the thick DLS which is suggestive of quiescent MNV, and the quiescent MNV is what is protective against GA is what we understand from this case. Another case of a foveal sparing GA, we can see at presentation the fovea is still unaffected. Over 12 months, we can see that there is an enlargement of GA at some points, but it has not migrated towards the fovea. When we did an OCTA, we could see that like there was a DLS in between the geographic atrophy and fovea, and probably this would have protected this eye from progressing into geographic atrophy towards the fovea. So, but at 3 months, he developed into a mixed type 1, type 2 CNV, as we can see that there is an additional subretinal hyperreflective material and intraretinal fluid. So, we treated him with a less aggressive approach, a PRN regime, a 6 anti-VEGF over 1 year, and we can see this over 2 years. We can see that like though there is an enlargement of geographic atrophy like away from the fovea, the presence of the DLS, a CNV at this area probably protected this area till now, and it has not progressed to a foveal involvement. So, to summarize, type 1 MNV is a protective against GA, and DLS is a surrogate marker for it, which is mainly the thick DLS. So, the clinical implications would be that there is no harm in avoiding treating the quiescent MNVs. We can just observe them, and the other thing is like in coexistent foveal sparing GA and active MNV, a less aggressive anti-VEGF treatment approach would be preferred, such as using a PRN regime and avoiding treatment of the stable fluid in cases with MNV. Thank you.
Thank you so much, Pradeep. That was really a nice case, very nice presentation of different approaches in these cases. So I was wondering, at least for me, if I suspect an example which you showed where there was a bump coming up as a shrum and the IRF, how frequently do you actually advise for an FA-ICG, or today your decision is solely based on structural OCT, or you also had OCT angio?
So this was 2 years ago. Like I have done FFA and OCTA, and it did show a leak at that point, and there was a neovascular network which we could detect. So we proceeded with treating with anti-VEGF therapy. I don't have ICGA, so I haven't done, but FFA did show leak at that point.
Just to tell everybody in the audience that there is a QR code, so please scan that code and ask your questions. But I would rather prefer somebody gets up and picks up the mic. That's more interactive. Dr. Talwar?
I wouldn't use an FA leak as a marker for CNVM in this situation, because it could happen just from a little bit of RPE changes could give you that false impression. Either you use an OCT angio or you use an ICG. So without either of them, how do you say it's an MNV?
Pradeep, do you want to take this?
In this case, OCTA showed the presence of network. So, like,
yeah,
I haven't
so if
included that image. I have only included the flow signal over there. The end-phase OCTA also showed the presence of a network.
Yeah, but...
And it has shown progressive growth despite PRN regime treatment. We have seen that that network is still good, has shown some growth actually.
Do you modify your anti-VEGF therapy approach when you see a patient with GA and a shallow or a very early CNV or a persistent CNV?
In patients with GA, I explain the patient that like a regular anti-VEGF therapy has been shown to be have shown to worsen the GA. So I do explain it to the patient, and I tell that like I would probably take a less aggressive approach, and even tell the patient that there may be others who may consider treatment at this stage, but I would wait. I would explain it to the patient clearly earlier.
Okay. Could I ask it? How frequently would you follow up of these patients? Because once you see the DLS, you know that there would be always a time that it would get active. So how frequently would you follow up all these patients?
I personally, if I see presence of DLS and the GA, these are the patients, mostly they are coming for their fellow eye. They are coming mostly for their fellow eye, so we are keeping an eye on that. And say that, both eyes are still dry and they have DLS with GA, I usually tend to call them 2 to 3 months, but I mostly do telemedicine, so they get their scans done, and they are more vigilant about their change in visual function. So around 2 to 3 months. Apurva?
Sure. It's important to know that DLS can be non-neovascular also, and that is a very important predictor of GA. In fact, they have seen, in my talk also I showed that thin DLS, if it is non-neovascular, there is no MNV, it quickly becomes GA. It's an independent risk factor for GA. That we have to make that distinction with.
Yeah, I will take Kelvin's opinion on this. He has been quite some time. So I know that we all struggle with looking into the DLS, especially I get lost when I'm dealing with the basal lamellar deposits, and you are not sure whether there are like thick RPE or there are deposits, or there is still a persistent MNV. So Kelvin, how do you follow these patients with outer retinal changes, what nicely Apurva brought up?
So I think I've come to this conference several times now, and I think I've seen the evolution. I think OCTA is really the key for this. And I use my OCTA a lot in these patients just to determine whether there's an MNV or not. If there is an MNV, then I do follow them likewise, quiescent MNV about 3 to 4 monthly. We did a longitudinal study in Singapore, and we found that they become active at about 6 months, so on average. So 3 to 4 months is reasonable to catch any new activity, and then we start treatment then. Obviously, if there's no flow on OCTA, it doesn't mean that it isn't there. It could just mean that your OCTA is not giving you the good resolution to pick up the MNV. Then I'll continue to follow up with OCTA until I detect anything.
How aggressive do you get when you see any fluid coming up?
Yeah, so I mean, this is the debate about whether anti-VEGF is the cause of GA so my belief personally is actually the disease activity itself. So we found that in eyes with very little disease activity, then you have higher risk of developing atrophy. That goes together with how much anti-VEGF you give, obviously, right? So in these eyes, I actually try and extend them out as much as I can. And I find that these lesions are not particularly very aggressive as well. So you don't lose a lot of vision even with a bit of fluid. So I think it's still okay to keep them a little bit wet. I don't chase them down until they're completely bone dry.
Any other? Yeah, Dr.
Yeah, Pradeep brought up a very, very important question, which is of like relevance right now. The presence of geographic atrophy with the activity of CNVM. So what would be the indications for treatment? Would be the vision that you look at? If the vision drops, you treat? Or are there any OCT markers which will say if the fluid is increasing or if there's IRF or a subretinal fluid, what makes you treat? So I usually wait and, as Pradeep said, we prolong as much as possible if the vision is stable. And if it's just IRF, I watch. So what are the opinions from the others?
I personally feel that it is important that to look for if there is any shrum, because I think that tolerating type 1 or type 1 type of fluid is still acceptable. Having a type 2 where Pradeep nicely showed that there was a breach and which led to CNV, those are the cases where you really want to start treating. But my usual approach for if I see a type 1 with a subretinal fluid, just sit on it and let's see how it does.
Now, I mean on follow-up. You have started treating the patient. When would you re-inject is what I wanted to know.
I would again depend upon patient symptoms if they feel that it is worsening, or looking into the fluid, or if I see that there is an increase in intraretinal fluid. In those situations, probably, there is some further worsening of the activities going on. But shallow SRF fluid, we can quietly observe. Any other questions? Any thoughts? Pradeep, while we have 40 seconds left, I wanted to ask you one more last question, that if you are dealing with a DLS, so just to summarize in one line that, whether there is a DLS, a thin DLS, or a thick DLS, or subretinal fluid, or intraretinal fluid, or shrum, which biomarker you want everybody to worry about most?
As the biomarker to worry about the most, as Dr. Apur was mentioning, the intraretinal hyperreflective foci is something which even I consider that has a higher risk of, as most of the articles are also suggestive that it has a higher risk of progression into GA. And even the thin DLS, which is not a quiescent MNV. So a thin DLS is something probably is associated with higher risk of progression to GA.
Okay, great. Thank you so much. I am sorry that I had to cut down here and move on to the next talk, but the good part is that our GA